I think we can go ahead.
So good evening, everyone. A very warm welcome to our respected faculty, delegates, and students to yet another interesting session of core masterclass in nephrology, with the topic today being management of membranous nephropathy. With this, I again extend my sincere thanks to our conveners, Dr. Vinay Sakuja, Dr. P.B. Verma, and Dr. Vijay Kher, and request them to kindly introduce and welcome our faculty for today. Thank you.
Thank you very much, Puneet, and thank you very much, Steadfast. We are back again with another interesting session on membranous nephropathy. We all know that membranous nephropathy remains the commonest, one of the common glomerular disease, especially in adult population. Today, to discuss the case, we have got Dr. Diksha Singh. She is a first-year DNB resident from Fortis Group of Hospital, student of General A.S. Narula. And General Narula, a very renowned nephrologist, very senior nephrologist and respected nephrologist. He has got the huge experience of close to 35 to 40 years in the field of nephrology. He is the examiner for her student, and the expert today is Dr. Raja Ramachandran, who is the additional professor of nephrology at PGI Chandigarh. We all know that Dr. Raja is a wonderful uh, academician and much sought after teacher, and he has got special interest in the field of membranous nephropathy. He has got a lot of work. So I think it'll be a pleasure listening to him also. The expert for today is none other than Professor Rajapurkar, again a tremendously respected member of nephrology community of India and abroad. He is not only well known in India, who was an ex-director of nephrology and transplantation at Mujibhai Institute at Nadiad. He's an IO winner of one of the best teacher awards he has got. He has been the ex-president of Indian Society of Nephrology and a very respected member of nephrology community. He is the expert today. The co-moderator with me is Professor Sakuja. I think he should be joining soon. Uh, and not to delay the issue, I'll request Dr. Diksha to go ahead and start the presentation.
Thank
Professor
you, sir.
Narula.
Good evening, respected teachers, seniors, and my dear batchmates. Myself, Diksha Singh, is going to present a case of 28-year-old female. She is herself gave her history and it's reliable. She is graduate by education and date of presentation was April 2025.
Diksha, can I interrupt you here for a second?
Yes, sir.
How do you give that certificate of reliability?
The patient GCS was full and she was
not that way. The reason I'm saying that is many
Yes.
adults who take insurance and try to fraud you.
Yes, sir.
You are saying reliability.
Recording in progress.
You and me can't say that they are reliable because we don't have the mechanism. We take a history and record it in good faith.
Yes, sir.
That is important to realize because you can't call it reliable. You will be held for being reliable.
Yes.
So if she says 4 months and it's actually say 2 years and she has taken insurance 3 months back and she gives you this history, you record it as she gives you in good faith. The reliability you can't mention. This is a practical point, nothing against you. Many people have this habit, so you better be careful about it.
Thank you, sir, for your guidance. So the presenting complaints were patient was apparently asymptomatic.
Again, one more. What is asymptomatic? How can you see symptom? Apparently, what is apparently? Again, mistake of English, but it sort of changes the meaning. You can't see somebody asymptomatic.
Yes, sir.
You're seeing me. Can you say I'm asymptomatic or not?
No, sir.
You can't say.
No.
That's why don't use that word.
Yes, sir.
Patient was asymptomatic is understood.
Yes, sir.
Okay. You go ahead that patient narrates that history of last 2 months, whatever. But
yeah,
remove the word asymptomatic.
Yes, sir.
An apparent part of it.
Yes. Patient was asymptomatic 2 months back when she developed insidious onset, gradually progressive, bilateral lower limb painless swelling with facial puffiness. She also complained of weight gain of about 8 kg and postural.
Diksha again.
Yes, sir.
Weight cannot be about.
Yes.
Either you know the weights before and after, or you can say there was severe weight gain, the clothes became tight, or whatever it might be. But it
Yes.
can't be about.
Yes.
Okay.
Postural symptoms of giddiness and frothy urine from last 2 months. There was no history of fever, rash, arthralgia, epistaxis, redness of eye, headache, blurring of vision, and seizures. She also didn't give history of sore throat, hemoptysis, chest pain. There was no history of reduced urine output, dysuria, flank pain, or gross hematuria. There was no history of any palpitation, breathlessness, abdominal discomfort, yellowish discoloration of eyes. And there was no history of any localized calf pain or tenderness, any hair loss, or irregular or heavy menstruation.
Diksha, can you explain that
Yes.
in a patient, in a young woman of 28 years who presents to you with only edema,
Yes, sir.
what are these no histories that you are telling, and what are you trying to make us believe that the person doesn't have? So when you say no history of rash, do you think a lupus would present just because she is female? That would be lupus 5, is it? 4, what?
Sir, I believe that as I am explaining, there's no constitutional symptoms in this patient to rule out.
Why epistaxis? Why redness of eye? What are you trying to tell us?
There's vasculitis. I'm trying to rule out vasculitis.
Does any vasculitis present with edema?
Sir, no, sir.
No, sir. The next, sore throat, hemoptysis, chest pain. Why that?
Sir, for the same reason I took it.
Okay, why this reduced urine output, dysuria? Why would dysuria present as an edema?
That dysuria, sir, can present if.
Why will it present as edema?
No, Diksha, if you're not able to correlate, just say I'm not able to correlate. I just said it to complete my history.
Yes.
Okay. So I think as a general guidance, when you come to this stage where you are trying to tell no histories, then you have something in mind. One is that the diagnosis is nephrotic syndrome in a 28-year-old woman.
Yes, sir.
Okay.
Yes,
so
sir.
what are the common causes? And therefore, you rule out the common causes in the order of commonness. Your no history should be relevant.
Yes, sir.
I mean, completing the history, as General Sir says, is correct. But there are things which you have to be careful about in any given clinical case. Okay?
Yes, sir.
Okay. Go on.
Sir, family history. Patient mother had hypertension. There is no history of kidney disease in family. There was a history of pulmonary coughs in sibling. Personal history. She was mixed diet. No history of taking any recreational drug. Normal sleep and bowel habit. Regular menstrual cycle. Sir, my history is finished. Now I'll go into.
Can you summarize the history?
PP, she'll do it after this. After the examination, she'll summarize the whole thing.
All right. All right.
Sir, in examination, there was no postural hypotension. Pulse rate was 88 beats per minute regular. Weight was 75 kg at presentation. Temperature was afebrile. No pallor was present. Edema was pitting bilaterally till mid thighs. Icterus cyanosis, clubbing and lymphadenopathy was absent. No rash or joint swelling or any tenderness or any skin changes. Systemic examination was within normal limits. All respiratory, CVS, abdomen, CNS, and extremities. Sir, I've also done urine analysis as part of my examination. pH was 6, color was slightly hazy, specific gravity was 1.010 per 1010. Protein was present +2. Sugar was not detected. WBC was 2 to 3. RBC was nil. There were granular cast presence. Crystal was absent and leukocyte esterase was negative.
Yeah, now sum up.
Yes, sir. A 28-year-old female presented with dependent lower limb edema and morning facial puffiness of 2-month duration with postural hypotension. She had no constitutional symptoms and clinical examination was negative for involvement of liver, heart, joints and skin. The urine analysis showed 2+ albuminuria with granular cast.
Okay. So, Jalvama, can I take over from here?
Please, please.
Okay. Diksha, like Dr. Rajapurkar was saying,
Yes, sir.
he was coming to your syndromic diagnosis.
Yes, sir.
Now, which system do you think is involved in this lady?
Sir, in this lady, renal system is involved.
And why do you say it is the renal system and not the heart or the liver?
Sir, because she doesn't have any other symptoms relevant. She doesn't have any palpitation, chest pain, breathlessness, or any other symptoms which would point towards other involvement.
Yeah. So when you say that you think the renal system was involved, what do you think is the syndromic diagnosis in this patient?
Sir, most likely my syndromic diagnosis is nephrotic syndrome.
Why do you say that?
Sir, because she didn't complain of any hematuria, so and
No,
she
no.
had,
Why, what guides you to say it is nephrotic syndrome on
Sir,
your
first-
clinical examination?
Sir, first it was gradual, develops over days. Second, sir, the patient had pitting edema in both lower limbs. Third, it was bilateral and symmetrical. And fourth, frothy urine was also present along with that.
No. So I think what took you in that direction was the edema.
Yes, sir.
There was no hypertension.
Yes, sir. No history of hypertension.
She had proteinuria.
Yes, sir.
The other sediments were bland. There were no RBCs or RBC casts in the urine.
Yes, sir.
No, so that is why you're thinking that this I could be dealing with the case of nephrotic syndrome.
Yes.
Now, again, Dr. Rajapurkar asked you a very nice question. He said, why have you stressed on a full slide the negative history, negative history, negative history?
Sir, a young female presented with me. First thing my mind goes is SLE. And in lupus, sir, we can have vasculitis symptoms.
No. You didn't listen to him carefully. He was telling you that lupus or vasculitis will not present like this. Now you have you have done the urine analysis.
Yes, sir.
No?
Yes, sir.
So based on your past history and based on what you're seeing now, do you think you're dealing with a primary glomerular disease or a secondary glomerular disease?
Sir, primary glomerular disease.
So you think you're dealing with the primary glomerular disease and a nephrotic syndrome. Good.
Yes.
So what is this proteinuria 2+ that you mentioned? What does it mean?
Sir, it is approximately, if we go in the form of albumin, it's 300 to 1000. And
No,
if
how
we
was it
see,
measured? No, you didn't get how was it measured by a dipstick?
yes, sir, it was measured by dipstick. I did a bedside examination.
So what does the dipstick show? Albumin or protein?
The protein is shown in dipstick.
Predominantly albumin.
Yes, sir.
No, dipstick shows predominantly albumin.
Yes.
Right? Although it is loosely mentioned as protein.
Protein. Yes, sir.
So which other method you know where you can detect protein in the lab yourself?
Sir, by by heating the urine, we can also see protein.
By sulfosalicylic acid.
Yes, sir.
So when you get a disconnect between albuminuria and proteinuria, can you think of any condition?
Yes, sir. We can get in multiple myeloma. In that, overflow proteinuria is present and no albumin can be detected. We can also see in, sir, small protein loss, albumin is minimal,
So
like in tubular proteinuria.
correct answer would be in non-glomerular proteinuria. There may be a disconnect between the dipstick and the sulfosalicylic acid method. No?
Yes. Yes, sir.
Then you showed us some granular cast. What does it mean?
The granular casts are generally degenerating cellular debris and plasma protein, mainly termed horsefall protein.
So does it indicate the patient has got a glomerular disease, a tubular disease, or is it something overflowing?
Sir, it generally indicates tubular injury, but a coarse granular cast can be present in glomerulonephritis and nephrotic syndrome
So
also.
a glomerular disease in which the cellular elements have degenerated.
Yes, sir.
Now, actually, the next step would be to ask you, looking at the granular cast, can you say if it is acute or chronic? But I leave it at that because long-standing chronic kidney disease can present with broad granular casts. But we'll leave it at that.
Yes, sir.
Now, why did you take? You mentioned something about frothy urine. Now, what is this frothy urine? Is it significant?
Sir, frothy urine is specifically not significant, but it's relevant in our condition as protein is a surfactant and it gets foamy urine is formed in that. Uh,
So, is it a diagnostic criteria for proteinuria?
no, sir, it's not a diagnostic criteria.
So, any other substances in the urine can cause froth?
Yes, sir. Common substances like bilirubin can cause froth.
Bile acids and bile
Bile.
salts, they are also surfactants
Yes.
and they can cause frothiness in the urine. Now, why did you ask about the family history?
Sir, family history is very important in this condition because I was thinking of nephrotic syndrome and familial clustering is rare but reported in genetic forms.
At 28, at the age of 28?
Yes, sir.
No, you didn't get it. That's a very relevant question. When you get a family history, what should be the age of the patient?
Sir, age of the patient should be less. Means she should be pediatric age group.
Yeah. So, when Dr. Rajapurkar asks you something, you have to be very, very careful
Yes, sir.
as to what you're answering because he's going by your clinical presentation.
Yes, sir.
So we think that we are dealing with a case of that this young lady has got nephrotic syndrome, and you think it's a primary glomerular disease and not a secondary glomerular disease. Okay.
Yes, sir.
Can you show us the slide? Anything else you would like to ask us, sir, on this?
I would want to ask her that what do you think are the possible causes of this nephrotic syndrome? I'm prepared to accept that this is primary glomerular disease, nephrotic syndrome in a female age 28. I'm presuming unmarried and has no previous obstetric history, though it has not been said, which I think you should have said before.
Yes, sir.
But so what in the priority list, what is the most likely cause of this nephrotic syndrome?
Sir, it should be, sir, membranous nephropathy.
Where is the evidence to say what is the commonest and then next, then next, then next? Is there any such literature you know of?
So, Diksha, what are the Indian studies which show you the common histopathological patterns in young people who come with nephrotic syndrome? Are you aware of any one or two studies? You are not sure? It's all right.
Doesn't matter, no problem at all. But if you just list the number of primary glomerular diseases which cause nephrotic syndrome without any deposits, what would they be at the age of 28 in a woman?
Sir,
would you like me to prompt? What do you think of FSGS?
FSGS.
Yeah.
What about minimal change?
Sir, minimal change is generally less than 12 years, but it can present in adult. Means she can be presented in
minimal change is not only in children, even
yes.
in adults, it's quite
yes.
common.
Yes, sir.
Okay. What about you already are stuck up with membranous because you know the diagnosis and somebody has told you in your, but you're not ruled. What about amyloidosis? Somebody who presents with that kind of a blood pressure. You didn't tell us any treatment that patient received during that 2 months. If she had received diuretics, maybe postural hypotension could have been considered. But I would think amyloidosis also should be considered at this point of time. Particularly, we don't know her tuberculosis status.
Sir, I'll tell treatment history in next slides.
That will. We're talking of at this stage. You can't rule out amyloidosis.
Yes, sir.
So, Diksha, what is trying to tell you is that you have minimal change, you have FSGS, you have membranous, and then you may also have amyloid. The Indian studies you have forgotten, but remember we discussed it. The SGPGI group told you the most common cause was FSGS in their young population. The PGI Chandigarh group said less than 40 years it is FSGS, more than 40 years it is membranous. I don't know what is the experience in the West. Probably Dr. Rajapurkar could tell us to complete it.
Well, I think the list goes the same way, roughly. FSGS, minimal change complex, followed by membranous, followed by amyloid, for those who have no deposits in the urine. CMC also presented their data some time ago and was similar. But the problem with most of these studies is that they are retrospective analysis of biopsy data and not necessarily the same as you think it is. Okay. I think it's a good idea to do the search and find out for yourself. You still 2 more years to go for the exam, so you can complete that when this is over. Nothing against you. This is common. Happens.
Yeah, next.
Sir, in all investigations, her creatinine was 0.6 normal. Serum protein and albumin was 5.8 and 2.6. Her lipid profile was elevated. LDL was 166, triglyceride was 240, cholesterol 320, and rest parameters were normal. ANA was 1 plus 1:80 dilution, homogeneous pattern.
You think that is positive ANA or negative?
Go back.
Yes.
What is the significance of that ANA that you're talking of?
Sir, it's generally not significant, 1 plus.
But then you should say that immediately, because up to now you're not thinking of lupus at all.
Yes, sir.
Right?
Yes, sir.
Right. Then what do you think of that calcium? Why is that calcium so low? Is it normal or low?
Sir, it's normal because albumin is 2.6. If we calculate corrected calcium,
what it will be?
Sir, it will be approximately 8.8.
Very good. Very good. Go
okay,
on.
Next slide.
Yes, sir. Sir, her UACR and UPCR was elevated. UACR was 3627 and UPCR was 8.25. USG was...
Now here I'm a bit confused about your 2 plus and this urine protein to creatinine ratios or protein to albumin to creatinine ratios seem completely discordant. I mean, it doesn't say 2 plus spot urine.
Yes, sir. When she presented, sir, and we did a bedside, then it came 2 plus only. But afterwards, in urine examination, also it came 4 plus.
Oh, you missed the question. Question is, when is there a discordance between the 2 plus on a dipstick and the measurement of UPCR? Can it be discordant?
Yes, sir, it can be discordant.
Yeah. So what are the conditions which lead to a discordance between a dipstick and the measurement?
See, you have more than double the protein compared to albumin in urine here, if these two are to be taken into consideration.
Yes, sir.
Why should that be? So start thinking about it. And why is it
what are you measuring in UACR?
Sir, we are measuring albumin in UACR by creatinine.
You're measuring albumin. And what are you measuring in UPCR?
Sir, protein. All the proteins.
They will be concordant only if only albumin is coming.
Yes, sir.
In which nephrotic syndrome, it is predominantly albumin.
Sir, in minimal change.
So if it is minimal change, then you can have a similarity between UACR and UPCR.
Yes.
If it is not minimal change, you don't expect that.
You know any tests for selectiveness of the proteinuria?
There is a formula, what we call selective proteinuria. What is that, if any idea?
That will be too much for her.
No, see, if you have this kind of a thing, you look at if there are more proteins coming out, it means it's a more dangerous disease.
Yeah.
Yes, sir.
Where, except in amyloidosis, where you have predominantly albumin coming out, and it is a selective proteinuria. When you so find out what is the ratio and just send it on the group later on.
Okay, go ahead.
Yes,
After
sir.
X-ray chest,
Sir,
what
with
was the
the
PLA2? What was the PLA2?
sir, PLA2 was negative. One minute, sir.
Negative. Okay.
Yes, sir. So it was less than 0.60.
Okay.
Okay, don't play around with your slides. Just go on to the slide on histopath.
Yes, sir. With the clinical diagnosis of nephrotic syndrome and normal ultrasound, we did a ultrasound guided kidney biopsy. On biopsy, sir, a total of 11 glomeri was seen. On hematoxylin and eosin stain, glomeri appeared normocellular and interstitium appeared normal, as you can see here.
Okay, next.
On the past stain, glomeri appeared enlarged, normocellular.
Wait a minute, please. What do you mean by glomerulus is enlarged here? This is 400x and that was 200x.
Yes,
so when
sir.
you say glomerulus is enlarged, what do you mean?
Sir,
we don't actually measure it, do we?
No, sir.
Then you must have some guide to say whether it is a larger glomerulus or small glomerulus. And in a nephrotic syndrome, when you get glomerulomegaly, what about obesity?
Sir, in FSGS also, sir, secondary FSGS, obesity, we can get glomerulomegaly.
Do you think this is glomerulomegaly? Or is it reported as?
Sir, it's not glomerulomegaly, sir.
No. You don't go. So it was reported.
Don't get confused, dear. Don't get confused.
Yes.
You put it as appears enlarged. So you must compare it with what? Do we compare it with a horizontally cut section of the which tubule? Proximal or distal?
The proximal tubule.
Okay.
Okay. So it was normocellular and diffuse thickening of basement membrane was present.
But if you wanted a stain for suspected membranous, would you be satisfied with only pass?
No, sir. I'll see silver stain also.
You have silver stain?
Yes, sir.
No.
No, sir. No, we didn't had.
You didn't have silver stain?
No, sir.
What about immunofluorescence?
Yes, sir.
Did you have immunofluorescence?
Yeah, but she's only showing the IHC.
Okay.
Sir, in IHC, anti-PLA2R was positive. Granular positivity was along the glomeruli capillary wall.
Okay. Next.
Sir, we had only these slides with me.
Okay, these are good. Why are you apologetic? Okay.
Sir, on the basis of history, examination, and biopsy finding, my final diagnosis was nephrotic syndrome, primary membranous glomerulonephritis, PLAR2 biopsy positive.
Diksha, two small questions.
Yes, sir.
How do you say that there was thickening of basement membrane? Is that your feeling, or how do you compare with what?
I don't know.
Are you comparing with tubular basement membrane? And then you say it is thicker than that. All right.
Yes, sir.
And what is nephrotic syndrome? Because you are first year student, you can just tell us what is nephrotic syndrome and why did you call this as primary membranous glomerulonephritis?
Sir, nephrotic syndrome if proteinuria is more than 3.5 means in urine, then we call it nephrotic syndrome along with hyperlipidemia. In adults, sir, I am telling, along with hyperlipidemia or edema.
Not all. And edema.
Yes, sir.
Diksha, can you, in your slide, you had mentioned about hyperlipidemia.
Yes, sir.
So what do you think leads to hyperlipidemia and nephrotic syndrome?
Sir, in nephrotic syndrome, the lipoprotein lipase activity, liver activity increases.
Mm-hmm.
LDL, VLDL, and cholesterol are increased.
No, so I think you're getting a little confused. Diksha, two things. Either there is an increased production in the liver, which
Yes.
may be due to the fall in oncotic pressures,
Yes, sir.
increased synthesis of lipoprotein,
Yes.
or they may be reduced, or
Sir,
they may
reduce excretion, sir.
not excretion, they may be reduced catabolism because of fall in the LDL receptors.
Yes.
So the LDL component stays in the circulation. There's a decrease in lipoprotein lipase activity in the liver, so the cholesterol levels start going up. All right, that is why you have hyperlipidemia. Then you mentioned another thing about the low albumin. Why do you get low albumin in nephrotic syndrome?
Sir, proteins, sir, because it gets excreted in urine, sir.
That may not be the only reason, no? So again, the two things, a small fraction due to excretion in the urine, more important, suppression of albumin synthesis in the liver. That is what happens in nephrotics. So that is why you get such severe hypoalbuminemias in them. Now, what General Verma was asking you, that why do you say it is nephrotic syndrome? You mentioned 3, 4, and then you mentioned, I'm saying in adults, not in children. What is it different in children?
Sir, in children, the value is different. It's 2.2. And sir, and in them, sir, we need all the parameters, means edema and hyperlipidemia.
So suppose you have 3.5 gram protein like you're mentioning, and there is no edema. Then what do you think of?
Sir, it's asymptomatic nephrotic syndrome.
No. Then it's not a nephrotic syndrome, no? It's
Not syndrome, yes, sir.
It's a nephrotic proteinuria.
Yes, sir. Asymptomatic proteinuria.
So
It's a nephrotic proteinuria. You say, and keep in mind also, when you are giving definition, it is 3.5 gram per 1.73 square meter body surface area in presence of normal kidney functions.
Yes, sir.
If the kidney functions are bad, if a person is having already creatinine of 4, this formula will not be applicable.
Yes.
All right.
Yes, sir.
Yeah, very important what he's just told you.
Yes, sir.
All right.
Yes, sir.
Yeah. Okay. Now, can you go back to your biopsy? Can you show us your biopsy slide? Because there, show us your light microscopy.
Yes.
Now, just looking at this slide, and what you see, you told us the glomeruli appear normal. Suppose there was some proliferation in the mesangium, what would you think of?
Sir, IgA nephropathy.
No. Okay, IgA nephropathy. Okay, fair enough. One of the causes. So you'd also like to think of a secondary cause.
Yes, sir.
That is happening in these people. No, that is what you should see.
Yes, sir.
Then you go to the next slide.
Yes.
And the next one, you said it was the past. Go to the next one, please.
Yes, sir.
Yeah. So you said you found anti-Pla2 staining on IHC.
Yes, sir.
That means that antigen is there. Pla2 antigen is there.
Yes, sir.
You didn't tell us what was the class of antibodies they detected in the biopsy. What did they report? The class of antibody.
Sir, G4 they reported.
IgG4.
Oh, yes, sir.
Is it important to know what type of IgG it is?
Yes, sir. In primary membranous, we generally get IgG4. In secondary, we get more of 1, 2, 3.
Okay. Are there any primary membranous antigens where you can get IgG1 codominant with 4 or just IgG1?
Sir, from Boston, we can get sir THS
No.
7A.
It's all right. If you don't know, it's all right. In children, when they have the sema antigen, you can get IgG1. Is there any where you can have a full house match besides IgG? You can have IgA, IgM, you can have C3, C1q. What condition does it take you into?
The lupus, we get
Yeah.
full house.
So it's important to mention the class of antibody. It's important to mention the antigen against which it has been found. That is why this histopathology was put up. So, how do you explain in serology PLA2 was negative, but on staining it is positive?
So there are 2-3 reasons for that. First reason is that the antibody may have been cleared due to the treatment. Antigen antibody complex may have been localized in the kidney. Already, the circulating antibody has complex with podocytes, and we didn't get in serum. Third can be sir epitope masking assay variability,
What
and
does that mean?
uh,
That's a very big word you've used. What does it mean?
sir means that in serum we are not getting because it's already getting deposited in the podocyte.
No.
So,
So, uh, I'll just explain to you. There is an antigen.
yes.
Within the antigen, you have epitopes, which are the actual components to which antibodies bind.
Yes.
And in the lab, when you test for PLA2, you've got synthetic or manufactured antigens, which may not be carrying the epitope. So that is why it may be negative there, but it may be positive in the when you do the staining with IHC.
Yes.
Okay, other than the reasons that you mentioned. Okay, can you go on to the next now?
Yeah, what treatment you gave to the patient?
Yeah.
Uh, from April to September, we kept the patient on supportive care with ARB, SGLT2 inhibitor, statin, calcium, and vitamin D. We also gave a pneumococcal vaccination. But the issue came of recurrent postural hypotension with this, so we cannot give our optimal dose.
Disha, 1 minute.
Yes, sir.
She already had postural hypotension. So why did you start both the SGLT2 as well as, because they will both act and tell me certain. And why rosuvastatin? See, tell me certain, I can understand you're trying to reduce. Dapagliflozin, I understand, but it behaves also as a diuretic. So
Yes,
your
sir.
patient is already got postural hypotension. Why would you start both these together?
Sir, first we started her on Telma for some days, but remission was not achieved, so we added.
For some days, meaning what? How many days?
So we gave her for 15 to 20 days.
So is that enough to judge whether you have achieved maximum ACE inhibition?
No, sir. We should at least give for 3 months.
So then what was the hurry? Why would you add DAPA just because it is available and you have just recently read DAPA CKD?
Yeah, actually, I don't think you were involved in the management. So what
Okay.
happened in this was that it was started initially on a very small dose of telmisartan.
Yes.
And in fact, we came down to 10 milligram to see if she's able to tolerate it.
Right.
And then tried to build it up. For some time, she held on to 20 OD, 20 BD, but again, the blood pressures would fall and we had to stop. So it was going up and down. So DAPA was started much later in the course.
Okay.
In lieu of a diuretic, she was put on DAPA.
So I'm not
Rosuvastatin was
trying
at
to.
the end of 3 months. It was
I'm not
not
trying to criticize the person who started it. I'm just
no,
asking her thoughts about it.
she didn't know about it because I don't
Okay.
think she was involved in that. And
Okay.
Rosuvas was much later at the end, almost at 3 months, when we found that the hyperlipidemia was not settling down, nephrotic range proteinuria was not settling down. But yes, postural hypotension was a very significant event in this patient. So basically, we could never
My,
give her conservative therapy.
my question is only that it is also like literature does mention that you should wait for 6 months for supportive care. But a person who is having postural hypotension, a person who is having proteinuria more than 8 grams, a person who is having all the symptoms, hyperlipidemia, I personally, I don't know the opinion of house. I may not have waited for that long in this patient. Maybe I would have given the treatment earlier because patient is having postural hypotension, which is all due to low albumin level, low protein levels. Oncotic pressure is low. And yeah, and I don't know, second question will be, which was raised, we will take the opinion of House, that tell me Sartan and DAPA, should we really wait for 2 months, 3 months? Or should we put all these drugs fast? It is something like when we are treating heart failure, the recommendation is within 4 weeks, all the drugs should be in place and to give it the optimum full dosage. Should we
Yeah,
wait for three
actually,
months?
these generic drugs should be started, in my opinion, at the first go. But this lady,
Yes,
her
yes.
blood
If
pressure
we
kept
are,
on
if we,
falling.
it is something like the new trials which are coming. Should we wait? Because what we have been having this thought process initially, मैं पहले ये start करिए, wait for 3 months, then you start DAPA, then you wait for some time, then you go for whatever MRAs. But now the trials do say you start them early. Take that maximum benefit early. Why one wants to wait for 2 months, 3 months, 4 months, and then start the treatment and take the benefit?
Yeah,
Anyway, this is a point for discussion. We will take
yeah,
Raja's opinion also, what
Sir,
it has.
one thing I would say at this point, when you are starting this treatment, you must first classify the severity of the disease. Is it mild
Yes.
disease,
Yeah.
moderate disease, high risk, or very high risk?
Diksha,
Depending
what is
on,
it? Is
I'm
Yes,
it
sir.
sure she'll tell us. She'll tell us. I'm sure she'll tell us.
it is moderate, mild, or severe?
Sir, it was high risk because proteinuria was more than 8 gram per day.
No, no, hold on. Don't go by proteinuria. Did she have a GFR less than 60?
No,
How
sir.
do you classify? How do you classify
Yes, sir.
mild, moderate, severe, or very severe?
Sir, mild is normal GFR with proteinuria less than 4 gram per day. Moderate is 4 to 8 gram per day and normal GFR
So,
or
what category does she fall into?
sir, moderate because high is more than 8
Hold on,
gram
hold
per
on,
day or
hold on. Go to the next. What is severe?
severe is sir, more than 8 gram per day or decrease in GFR less than 60 ml per minute 1.73 meters square.
No, let me clarify. I think you're getting a little confused. This is very important. Mild, there is no confusion. Moderate, there is no confusion. When you say severe, if you have a normal GFR and if you have proteinuria more than 8 grams, that's all right. It may be 7 grams, 8 grams, it doesn't matter. With one additional finding, that
Yes,
additional
sir.
finding is serum albumin less than 2.5
Yes, sir.
or or the PLA2 levels greater than 150 or 50 RU, then you say it is severe.
Yes.
So this lady fell somewhere in between. And that's what General Verma was saying, that he would have liked to start immunosuppressives much earlier in this patient rather than waiting. You get it now?
Yes, sir.
So in which category will you not wait at all? You will start at once.
Sir, in high risk category we will.
In the very high risk category.
The very high risk is life-threatening nephrotic syndrome or rapid deterioration of
Yeah.
kidney.
So you will not wait at all in that. You will start at once. So in this case, we could have started earlier. That's what he's trying to say. Okay, go on to the next.
Sir, from in October 25, we planned her to give rituximab 1 gram infusion, 2 doses, 14 days apart. But we got a history of her sister having died recently of pulmonary tuberculosis. So we got her HRCT test done and quantiferon TB beta gold. HRCT test was normal, but quantiferon TB gold test was positive. So, sir, in view of latent tuberculosis, we started INS prophylaxis in her for 2 months.
Yeah, just hold on. How common is latent tuberculosis in our country?
Sir, very common, sir.
It's very common. Then why did you think of starting treatment? Why did you not object to this treatment?
Sir, rituximab has a we should rule out latent tuberculosis because active disease will come.
So, in other words,
It's
in
a
which,
immunosuppressant.
in which cases of latent tuberculosis is it recommended to use prophylaxis? Any idea? So, go back. In immunocompromised, that is where it is suggested that you should be putting them on prophylaxis either with INH or rifampicin and INH for 3 months. Now, what is the significance of quantiferin TB gold test positive? How does it compare to the tuberculin skin test?
Sir, quantiferon TB gold test is positive in latent tuberculosis, and skin test is positive in all individuals. Means can be positive in.
The answer I was looking from you was that BCG vaccination may cause a false positive tuberculin skin test. But the quantiferin TB gold test, if done properly in a standardized lab, it does not test against the antigens used in a BCG vaccine. But they may be cross reactivity with other mycobacteria. All right. Okay. Now tell us what happened then.
Sir, then in October, we gave her rituximab after INH prophylaxis, but she developed acute infusion reaction, including urticaria, choking, stridor, hoarseness of voice, rhinorrhea, and extensive bronchi. So, in view of that, rituximab infusion was discarded and she was managed as anaphylaxis.
Go ahead.
Did you give any?
Sir, after that, we started.
Hold on. There's a question coming. Listen to the question.
Did you use any pre-treatment before giving rituximab, or only rituximab was given? Was it?
Yes, sir. Sir, we gave her Avil and Escorts before treatment.
In spite
then
of
also
that,
she developed anaphylaxis.
Okay, so I wish you should have stated that. Then the question wouldn't come. Okay.
Okay, next. Yeah, present this.
Sir, in October.
Yes. Make it fast because your time is almost over.
Yeah. You got only 2 minutes.
Sir, then we gave her tacrolimus 0.05 mg per kg in 2 divided doses plus prednisolone 0.5 mg per kg body weight, and dose was modified to keep trough level around 7 nanogram per ml. The issue came with this was TAC toxicity, tremor, tachycardia, hyperglycemia, insomnia, and also serum creatinine raised from 0.8 to 1.4 mg per deciliter. TAC dose was reduced from 3.5 mg per kg to 2.5 mg per kg. Prednisolone was tapered off, symptom improved, and serum creatinine became 1.01 mg per deciliter.
Yeah, the last slide.
In November 2025, she developed diffuse acute abdominal pain. Yes, sir. Nausea, vomiting, fainting spell. Clinically, pulse was 108 regular, PP was normal, no jaundice pallor, abdomen was soft with sluggish bowel sound, no neurological deficit. CBC, LFT, serum amylase, lipase were normal. Upper GI endoscopy was normal. CECT abdomen showed no feature of pancreatitis, mesenteric ischemia, renal vein thrombosis. EEG MRI head was normal. Tacrolimus was stopped with improvement of symptom over next 3 days. So we can see the trend here.
Next.
In x-axis there is time, means date in month, and in y. So we can see serum creatinine level and UPCR level. Initially, sir, it was 8.25 UPCR and it decreases to 4.5 in July after conservative and supportive treatment. And it remained in 4.5 till October when we started her on tacrolimus. It decreased to 2.69 with tacrolimus level falling from 6.8 to 8.92 to another than 6.62, and then increased to 5.94.
Okay.
So this is
Next.
the trend we gave in treatment. So on the basis of history, examination, and biopsy finding, my final diagnosis is nephrotic syndrome, primary membranous glomerulonephritis, PLAR2 positive, with history of latent tuberculosis, retux-related anaphylaxis, tacrolimus toxicity, CNS, diabetic, and gastrointestinal.
Chalo,
What are
good.
you going to give her now?
Yeah, that we'll wait for the
Rituximab, she has not tolerated. So logically, if there is a sensitivity, it is advisable not to give it. Tacrolimus, you said she developed toxicity. You had to stop it. What can you offer her now?
Diksha, are you there? You've disappeared.
Yes, sir.
Now give
No,
what
sir, I'm here.
option?
Sir, now we have two options left with her. One, we can give her cyclosporin, another drug in this cyclolimus that, and second, we can give her cyclophosphamide with steroid.
That is what Professor Rajapurkar asked you. You didn't give her history, marital history, that how many children
Yes,
she has got and what. Yeah. Okay.
yes,
Professor Narula, anything you want to comment before we go to?
Yeah, I'd love to listen to the house on this problem case. You see, at each step, there was a twist in this case. Right from the basis of diagnosis, not diagnosis, the management, whether we should wait for 2 months, 3 months, 1 month, 4 months, kept on dilly-dallying. And then the anaphylaxis, was it really an anaphylaxis or was it a transfusion reaction due to inadvertent rapid infusion of rituximab? It's very difficult when you're not monitoring it yourself. But I saw her symptoms and I'd be very hesitant to restart rituximab in this girl. The second thing was the tac toxicity that she had, and the acute abdomen was so severe that we thought she had perforated, and nothing came out on the CT scans. This fainting spell she had, were there a press syndrome that she had with tacrolimus? We really don't know, but the EEG and the CT scan heads, the MRIs were normal. Now comes, what drug can we use? She's categorically said she doesn't want cyclophosphamide and steroid pulses. She wants to have a family. So that leaves me with cyclosporin. Our plan is to start on a very small dose of cyclosporin and build it up. We wouldn't want another acute abdomen or a press coming on in this girl. Regarding the newer drugs, the newer monoclonal antibodies, they have a lot of cross reactivity with rituximab. And my own experience is zero, but I've read it that people have used it, and we'd wait for the house to tell us.
I think we will come to the questions also in the end, unless the audience has asked when to start statins in nephrotic syndrome. Second, it was that in primary membranous GFR less than 60 at the time of diagnosis, should we start immunosuppression immediately or still wait for 6 months? What about the postural hypotension? These are the three questions from the audience. Unless Professor Narula wants to answer them now, otherwise we will answer them in the end.
I think you
I'll
can do it.
request, yeah, I think now I'll request Professor Raja Ramachandran, I think who is a master and expert in the field of membranous nephropathy with tremendous amount of his original work, to say something, because membranous nephropathy is a totally different entity today. Rather, I would like that he touches some of the aspect. One is, can there be two antigens rather than one antigen, what we are saying? Now, there are almost 30 antigens which have already come in the forefront, and it is not possible to test them. Should we remain satisfied with only PLA2 or any other recommendations for any specific cases? And thirdly, whatever you do today, whether you are giving rituximab or something, if you talk of complete remission, it is only in 30% of the patient, 30-40% of the patient. Should we stick to that, or what the new trend is coming now, possibly that you are going ahead with many things? You are thinking of rituximab or other sort of monoclonals. People are thinking of beta cell therapies, other beta cell therapy. People are thinking about CAR T therapy for membranous. So I'll leave it to the doyen to talk about it. Raja, your turn now.
Oh, thank you so much, sir. Thank you. Good evening, all of you. Because of some exigency, I couldn't join you all earlier. Please accept my apologies. I'll start, I'll be briefly touching upon most of the questions that was being discussed during the discussion part. If I go to the questions which are pertinent to managing membranous nephropathy, is like, one is the therapeutic part, one is the pre-therapeutic part. So in the pre-therapeutic is, what is the natural history of membranous nephropathy? And what are the secondary causes, and what are the investigations we need to do before we actually start the patient on immunosuppressive therapy? And the third one is about the various antigens. We heard General Verma speak about various antigens. Every antigen is being added every other month, and now you have combination of antigens also. I think with all of these, what stands relevant even after 10 years is only the PLA2R, because we have a commercial antibody to test it. And coming to the therapeutic part, is what is the evidence-based management for membranous nephropathy, the long-term data. With rituximab, it is the short-term data. And are there newer therapies that are available? Unfortunately, they were available in India and they are now not available because it has been withdrawn from the nephrology segment. Obinutuzumab has been withdrawn from the nephrology segment. It can only be prescribed by oncologists in India. The last is about the management of resistant membranous nephropathy. So, workup leading to the treatment. How do you diagnose membranous nephropathy? I think there will be, I think it's going to be a very subjective answer. We diagnose membranous nephropathy at PGI by doing a kidney biopsy. However, this is not required.
Sorry.
Okay. You can also diagnose membranous nephropathy just by testing the antibodies. The data largely from the Western Hemisphere, but I don't think the data in the Indian context would be any different. So if there is any contraindication to biopsy, what we do is we test for anti-PLA2R by both ELISA and indirect immunofluorescence, and then proceed with appropriate management. In the past, there was always a talk that up to 20% of the patients with membranous nephropathy can have, some sort of secondary disease. Secondary, it could be malignancy, it could be rheumatological diseases. So the general workup is you test for antinuclear antibody, serum electrophoresis. I think this is common for any nephrotic syndrome. Viral markers. You also test for core antibodies. Why you test for core antibodies? If the core antibody is positive, even if the HB DNA is negative, when the patient receives immunosuppressive therapy, you generally give tenofovir prophylaxis or entecavir prophylaxis, depending upon the degree of kidney dysfunction or dysfunction. And what we do is we do a CT scan in all these smokers, irrespective of symptomatology. In females, a pap smear and mammography, urine for atypical cells in all of them, and stool for occult blood. Stool for occult blood, I think it's the best apology for screening malignancy. I think there are better ways to screen for them, but invasive techniques are, sort of patient do not agree for the invasive techniques. And in patients who have membranous nephropathy, especially PLA2R negative and history of complementary medicine, and who have segmental membranous positivity on indirect on immunofluorescence, please test their mercury levels, because most of them could be well-known membranous nephropathy. So coming to natural history of membranous nephropathy, it's always known as governed by disease of a third. 1/3 would undergo spontaneous remission, 1/3 would, undergo remission with immunosuppressive therapy, and 1/3, you would progress to chronic kidney disease. This is data of the past. Now this doesn't hold fort. So this is a nice study from the Toronto GN registry where they looked at the natural history of patients who had subnephrotic proteinuria. And what they found was, they divided the patients. 60% of the patients with subnephrotic proteinuria, progressed to nephrotic syndrome, and 40% did not progress to nephrotic syndrome. In patients who did not progress to nephrotic syndrome, they had a proteinuria of 1.9 grams a day. And those who progressed had a proteinuria of 2.4 or more than that. And when they saw the slope of the GFR, the slope of the GFR was minus 3.5 in patients who progressed to nephrotic syndrome, compared to less than 1 in patients who did not progress, suggesting that, if the patients progress to nephrotic syndrome, there is a risk of decline in the GFR. And in the PLA2R, the hazard ratio of progressing to nephrotic syndrome is much higher if the patient is anti-PLA2R positive. So coming to anti-PLA2R and spontaneous remission, you heard me saying that 1/3 of the patients with membranous nephropathy would achieve spontaneous remission. However, if you look at the titers, it is very clear that patients who have high titers, they do not undergo spontaneous remission. This was actually the basis why, the KDIGO recommended that, patients with a high titer, you should not wait. You can proceed with treatment. So, and what is the data on which they gave such a recommendation? There are at least 3 studies that I can say, but I'm sure that there will be many more where they looked at spontaneous remission and the anti-PLA2R titers. 2 of the studies suggested that, an anti-PLA2R of less than 97.5, there is a risk, there is a high success of spontaneous remission. And there was 1 study which showed that a titer of less than 40, there is high incidence of spontaneous remission. So there is always a debate between 40 and 97.5. The learning lesson is if we have an anti-PLA2R of more than 100, the probability of spontaneous remission is close to none. The KDIGO recommends that if it is more than 50 and proteinuria, you have it in nephrotic range, you proceed with treatment. Coming to, the biology of PLA2R antigen. PLA2R antigen it's got 3 domains: intracellular domain, then transmembrane, and extracellular domain. Most of the antibodies, Professor Narula spoke about the epitopes. So, it has got at least 10 epitopes, the PLA2R antigen. CSR is the cysteine-rich domain. This is the only domain that we test in the commercial laboratories. Then we have the fibronectin domain, and we have C-type lectin domain 1 to 8. So it totally adds up to 10. So most of the antibodies are IgG4 and they target to cysteine-rich domain. However, with passage of time, if you don't treat them properly, and in a cohort of patients who do not respond to immunosuppressive therapy, the antibody, there is switching or spreading of the antibodies from the cysteine-rich domain to C-type lectin domain. There is always a debate whether, this carries a good prognosis or a bad prognosis. The data from the French space suggests that, these patients carry poor prognosis, do not respond well to, the standard rituximab therapy of only 2 infusions. The German data suggests that it is not the spreading that is important, but it is the titer that is important. High titers, poor prognosis, and it is not the spreading. So this is somewhat debatable, but you should know about this aspect of the PLA2R antibodies as well. Coming to utility of anti-PLA2R antibodies in membranous nephropathy, if you look at the top 10 discoveries that have happened in the nephrology space, in the last 20 years, I think a detection of anti-PLA2R would figure up in the top 5. Before the xenotransplantation and other things, it was there in the top 2 itself. But now, with other things coming up, at least it would figure in the top 5 because it has revolutionized our understanding and also treatment of membranous nephropathy based on the antibody detection. The PLA2R antibody helps us in diagnosis and also choosing therapies. And once you give therapy, the best decline in the anti-PLA2R happens in the first 3 months. After that, the decline is not as steep as that happens in the first 3 months. With respect to cyclophosphamide and corticosteroids in the modified Ponticelli, if you look carefully, 50% of the patient would have antibody depletion at the end of 1 month. However, you cannot stop therapy because if you stop therapy, they will have a relapse. There are various models which have been constructed, to look into the prognosis of membranous nephropathy, where they factored anti-PLA2R, the age, the proteinuria, serum albumin, and the creatinine. I think the best model fit is at 3 months, where the change in anti-PLA2R and serum albumin is the one which determines the outcome. So if you have an anti-PLA2R of more than 300 at the end of 3 months, the prognosis is poor. These patients are less likely to undergo remission with immunosuppressive therapy at the end of a year or two. And, we had General Verma speaking about complete remission. Everybody wants complete remission. And with partial remission, the problem is there is always an uncertainty with partial remission. You can have somebody with 3.49 grams of proteinuria. He will be considered partial remission if his proteinuria baseline is about 8 grams. So if he becomes 3.51 grams, then he becomes a resistant disease. So, these kind of things, there is a lot of uncertainty about the proteinuric targets. What is now data which is evolving is, if somebody has a proteinuria of less than 1 gram, these patients are as good as complete remission. However, this kind of data requires validation in multiple cohorts. So if you look at the antigen in membranous nephropathy, the first antibody that was discovered was the neutral endopeptidase. It was discovered in a patient with collapsing membranous nephropathy, where there was a transmembranal transfer of these antibodies into the neonate, and the neonate also developed proteinuria, which resolved spontaneously as the antibodies, were, cleared from the circulation. Then we had the PLA2R, then thrombospondylin, and many more. Like, we have Professor Verma spoke about 30 antigens. They follow the Murray law of transistors, where, every year there is doubling up of the number of, the resistors in the transistor circuit. So here, again, if you look at the relevant antigens, I would say that PLA2R is the most relevant. If you look at the Indian context, it's about 75% of the patients are PLA2R related. And we had a discussion about, somebody having antibody which is negative and the tissue which is positive. I think the candidate rightly suggested that one is the patient has already entered immunological remission. The antibody has disappeared, only the tissue part is remaining. And the other is about the sink phenomenon. Sink phenomenon means the antibodies is secreted in small amount, it gets absorbed into the kidney. Only when the kidneys are saturated, then you will start these antibodies appearing in circulation. Thrombospondylin, not a very relevant antibody to the Indian context. We have tested even by serology, by indirect immunofluorescence, and we did not get in any of the patients. Some of the positivities could well be false positivity. Then what is relevant is NEL1 associated membranous nephropathy, very relevant in Indian context. It was discovered, they suggested that 1/3 of the patients with NEL1 membranous nephropathy suffer from malignancies. However, in Indian context, it's not the cancers that are important, but the use of complementary medicine. I will touch upon that in the last part of my talk. Semaphorins in pediatrics, that is less than 5 years. You have protocadrine, which is seen in older people, has very good prognosis. So, many antigens. I think what you can do is you can just open a textbook and, look at. Recently, this month, there was a publication by the Mayo Group by Professor Sethi, where they looked at, multiple antigens. What they found was there were patients with multiple antigens. Only thing that remains is, whether we are able to develop a commercial antibodies to test, something like the anti-HLA antibodies, the Luminex platform. I think that would be the best way, that would be the best platform to test these kind of antibodies. I suppose there are work in that space as well. We will get to know about that in the future. We also, there was a nice discussion which is happening about the risk stratification of patients with membranous nephropathy. It's largely dependent upon the proteinuria, then the anti-PLA2R and the serum albumin and the creatinine or the GFR. Mild, I think it's subnephrotic. Even during the discussion, it was very clear that mild means there is no debate on that. Moderate means proteinuria of more than 3.5 grams, but there is no decrease in the proteinuria to subnephrotic even after 6 months. High risk is one who have a GFR of less than 60, maybe a creatinine of 1.5 would be what, if it goes more than 1.5, the GFR would drop less than 16. And then our proteinuria of more than 8 grams. Or if the proteinuria is less than 8 grams, then you should either have severe hypoalbuminemia that's less than 2.5 or PLA2R antibody of more than 50 reference units. They become high risk. In very high risk is that, any life-threatening complications of nephrotic syndrome. So what are the life-threatening complications of nephrotic syndrome? One is venous thrombosis, or maybe arterial thrombosis as well, and then recurrent infections. The third part is there was also, the discussion about this patient was having postural hypotension because of severe hypoalbuminemia, was not tolerating, ACE/ARBs, diuretics was an issue. So, this patient would, if you ask me, where does this patient fall? I would say that the patient falls somewhere between the high risk and very high risk. Although, you cannot label anybody in between two risk stratification. But if you ask me honestly, it would be somewhere in between. And somebody who presents with RPRF would again be very high risk. What is important, if somebody presents with very high risk, then you don't debate about the kind of therapies. You straight away go to modified Ponticelli regimen, especially if there is an RPRF-like presentation. Yes, with venous thrombosis, maybe you can get away with rituximab, but if there is an RPRF-like presentation, you directly go with the modified Ponticelli protocol. With the high risk, you can either choose the modified Ponticelli protocol or rituximab-based therapy, or some say you can use that sequential therapy as well. Moderate is one where you could choose CNIs, rituximab, less so with the modified Ponticelli protocol. So if you come at the historical evidence for the modified Ponticelli protocol, this was the first therapy, this was the first publication in New England Journal of Membranous Nephropathy, which looked at 80 plus patients. To cut the long story short, at the end of long-term follow-up, what they found was, cyclical chlorambucil and methylprednisolone brought about sustained remission of the nephrotic syndrome, was able to preserve kidney functions, and also the safety profile was well tolerated. So this is another trial which is done from India by Professor Vivekananda from our department, where 93 patients with nephrotic syndrome were randomized equally to receive either only supportive care or the modified Ponticelli, that is cyclical cyclophosphamide and corticosteroids. To cut the long story short, there was a benefit. There was a mortality benefit, CKD progression, and dialysis requirement was low in patients who received modified Ponticelli protocol at the end of 10 years. It was only 1/5, that is only 20% of the patients had these kind of adverse complication, compared to more than 50% of the patients who received only supportive care, suggesting that, this modified Ponticelli arrests the progression to chronic kidney disease and end-stage kidney disease. And it has a mortality benefit and it improves the quality of life. So the only problem, there are multiple problems with the modified Ponticelli protocol. When a survey was done by Badran from Australia, what they looked at is what was the kind, modified Ponticelli protocol uses, large dose of corticosteroids and cyclophosphamide in an alternate fashion. And what they found was only 34% of the folks all around the world, use the traditional modified Ponticelli protocol. So if you look at that, so it's only 1/3 of them use the methylprednisolone 1 gram pulse. And with respect to India, it is still better. 42% of the folks use the, the standard modified Ponticelli. So if you look carefully among all the glomerular disease, kidney transplant, and also vasculitis, it's the membranous nephropathy where you give the highest dose of corticosteroids. You give more than 10 grams of or equivalent of prednisolone. You don't give so much even in vasculitis where you have the kidney function. Sarla, can you please mute?
Yeah.
So, so this is what, so actually, when you say that our patient has not responded to the modified Ponticelli protocol, it will be very much possible that they have not received the standard protocol. And the other points with the modified Ponticelli protocol is, there is a poor quality of life. Why I say poor quality of life is, one is the patients, there is an abrupt stopping of the corticosteroids. They received huge dose of corticosteroids and you stop them abruptly, then there is, withdrawal symptoms. And many a times, the patients attribute the withdrawal symptoms to introduction of cyclophosphamide. And what they do is they reduce the dose of cyclophosphamide, and henceforth, there is some amount of non-compliance. And also, we looked at the HPA axis suppression. What we found was 1/4 of the patients had evidence of HPA axis suppression because of the abrupt stopping of the drugs. Although most of them were asymptomatic, but this is something that we need to be mindful of. So, and with all these things, I think the $1 million question today is, is there a space for cyclical cyclophosphamide and corticosteroids in membranous nephropathy? I think the answer is yes. There are newer options which are available, which I will be discussing. Before I go to the next set of treatment, you should remember that an average about 60 kg man received receives about 13.5 grams of prednisolone equivalent and 13.5 grams of cyclophosphamide, which is huge. So looking at the dose of the cyclophosphamide and prednisolone the patients receive, we carried a randomized trial, which was published recently in Kidney International Report. We randomized 114 patients to only receive either prednisolone without the pulses and cyclophosphamide half of the dose that which is prescribed in the modified Ponticelli protocol. What we found, there was no the reduced immunosuppression was non-inferior to the standard modified Ponticelli protocol in patients with membranous nephropathy. The difference was 8% and it met the criteria for non-inferiority. The safety profile was better in the lower dose of immunosuppressive therapy. So what are the major recent clinical trials in membranous nephropathy? I think this is an article from Fernando Fervanza, which was published in Kidney International Report, where they suggested our study, which was on tacrolimus and corticosteroid versus modified Ponticelli, which reported the long-term outcomes. Then the GEM-RETEX trial, which compared rituximab to standard of care. Mentor trial, which compared it to cyclosporine. Starman is a site of sequential therapy, where they gave tacrolimus for 6 months, which is the Spanish practice, followed by rituximab at the end of 6 months. And then the ReCyclo trial, which is rituximab versus the modified Ponticelli protocol, which is the pilot study. See, in our study, where we compared tacrolimus with corticosteroids with cyclophosphamide, we reported the long-term outcomes. To cut the long story short, at the end of 1 year, the response rate was equal. But however, with every passing year, because of the relapse, it was clearly suggested that the tacrolimus and corticosteroid is an inferior to cyclical cyclophosphamide and corticosteroids. And the main problem is because of the relapse. Once you stop tacrolimus, there is increased risk of relapse. So some people may say, it's like kicking the disease can down the road. You stop the therapy, again you go back to the square one. So now before I go to the trials, what are the questions which are pertinent with membranous nephropathy and rituximab? First one is the role of rituximab in membranous nephropathy. That's important. Those are the trials that I will discuss. And is rituximab really effective in patients with very high PLA2R titers? Because there is always a suspicion that in high PLA2R titers, it doesn't work. Then the third one is in patients with kidney dysfunction, that's something like very high risk. Is rituximab useful or is it useless? Then about the resistant disease, is rituximab useful in patients who have resistant disease, who have not done well with tacrolimus or other CNIs, or even maybe the modified Ponticelli protocol? The first study is the GEM-RETEX trial, which compared rituximab to the supportive care alone. And what they found was there was no difference in the outcome between the two groups at the end of 6 months. But however, when they continued to follow up these patients till 17 months, they found that 2/3 of the rituximab treated patients responded compared to only 1/3 of the patients who received supportive care. And PLA2R declined quickly in the patients who received the rituximab compared to supportive care. The conclusion is, if you give rituximab, wait for some time before you declare response or resistance. 2, PLA2R titer is maybe a better marker than proteinuria at the earlier stage of the disease. Next is the rituximab versus cyclosporine in membranous, the famous Mentor study, which is published in New England Journal of Medicine, where they compared 2 doses of rituximab given on day 0 and day 15. And again, there was a repeat of this rituximab dosing at the end of 6 months if the patient did not respond. So many of the patients received 4 grams of rituximab compared to cyclosporine, a small dose of cyclosporine. And long story short, at the end of a year, rituximab was not inferior to the cyclosporine, but at the end of 2 years, rituximab was superior to cyclosporine in achieving remission in these patients. And the safety profile was also better in patients treated with rituximab compared to cyclosporine. So the conclusion is rituximab is better than supportive care, and rituximab is better than cyclosporine to manage membranous nephropathy. The third is a Starman trial, where they compared modified Ponticelli to a sequential therapy, tacrolimus for 6 months followed by rituximab. This is the Spanish protocol, where 43 patients in each group were compared. And what they found was patients treated with modified Ponticelli protocol did extremely well, and they had higher total remission rates and also complete remission rate. 60% had complete remission, Although you should remember that Caucasians have better remission rate with immunosuppressive therapy compared to Asians. And also the anti-PLA2R disappearance was much better in the cyclical cyclophosphamide compared to rituximab treated patients with comparable serious adverse events. So, the conclusion was it was designed as a superiority trial, but they found that, contrary, cyclophosphamide and corticosteroid brought in greater number of remission compared to the sequential therapy. The last, but one study is the recyclo study, where 70 odd patients, it was a pilot study mainly for the sample size and the feasibility, where 75 patients were compared. And what they found was at the end of year, 3/4 of the patient treated with cyclophosphamide and steroids responded compared to 60% of the patient treated with rituximab. However, when they continued to follow up these patients, 80% of the patient treated with rituximab or cyclical cyclophosphamide had response at the end of 2 years. The relapse rate somehow was more common in patients who receive cyclophosphamide and corticosteroids compared to rituximab, with safety profile very similar to the Starman trial. So, the conclusion was this trial was feasible, and but there was no signal of more benefit of or less harm with rituximab compared to the cyclical therapy. And this is, whenever we do a presentation, it is important we share Indian data. And this is a study from Nadiad, Professor Rajapurkar's unit, where 68 patients during the COVID times. I know these are all difficult times to carry clinical trials, were randomized to receive either cyclical cyclophosphamide and corticosteroids or reduced dose of rituximab. Here they received 500 milligrams on day 0 and 15, with 1 gram on day 0 and day 15. And what they found was at the end of a year, at the end of 6 months, there was no difference in the remission rates. Even at the end of 12 months, there were some patients who were lost to follow up, but the remission rate were largely comparable. And the adverse events were clearly better in patients who received rituximab compared to the modified Ponticelli protocol. It's a pilot study, and it clearly suggested you can do such a trial, but there is no signals to suggest that there is any difference in the remission rates between the two with respect to. But yes, patients treated with cyclophosphamide and corticosteroid did better than those who received rituximab therapy. So coming to the summary of all the study is simple. Rituximab better than supportive care, rituximab better than cyclosporine or maybe even tacrolimus. I'm just extrapolating. There is another study which is going on with tacrolimus and obinutuzumab. So, and rituximab may be as good as cyclical cyclophosphamide and corticosteroids. Rituximab induced remission happens after 6 months and it grows over time. So again, when you look at all these trials, you'll have to be careful, like, all these patients receive different dose of rituximab and they had different PLA2R titers also. If you look at the highest dose of rituximab that in the trials, among the 3 trials that I discussed, it was in the mentor trial where the patient received highest dose of rituximab. Despite receiving highest dose of rituximab, they had poorest remission among all the 3 trials, that Gemritix, Recyclo, and mentor trial. If you look at the Recyclo trial, it was intermediate. They received only 1 gram on day 0 and day 15, only 2 dose, whereas Gemritix was even lower dose, day 0 and day 7. So if you look what actually is the difference between the 3 trials, this is purely my analysis, is if in the mentor trial, the median anti-PLA2R was more than 150. So anti-PLA2R titer is important. Recyclo trial, the anti-PLA2R was only 63 compared to 102 with the Gemritix trial. So, Recyclo trial, they had higher remission rate at the end of 2 years compared to the mentor trial. So it could be the anti-PLA2R because largely the population was all Caucasians. So coming to, with that basis, I would, discuss about titer effect. Is there any difference in the anti-PLA2R titers and response to rituximab and cyclical cyclophosphamide? This is a very nice study from France, where France and the Nijmegen cohort, where patients with 2 groups, the French group was the rituximab one, and the Nijmegen cohort was the prolonged cyclophosphamide and glucocorticoid, where they used 6 to 12 months of cyclophosphamide and corticosteroids. What they found was, in patients with very high PLA2R titer, immunological remission rates was very poor with rituximab. Only 1/4 of them had immunological remission compared to more than 80% in patients treated with prolonged cyclophosphamide and corticosteroids. So the conclusion was, high PLA2R titers, rituximab doesn't do well. So what the authors went on to do at the end of 6 months, they gave an additional dosing of rituximab. And what they found was greater than 80% of the patient achieved immunological remission with the additional dose of therapy. Concluding that, if you give an additional dose of rituximab, it facilitates immunological and clinical remission. So it's important because what happens when you give rituximab in nephrotic syndrome, you give rituximab, most of the rituximab that you give would vanish from circulation in a very short while. We just, carried out an analysis of rituximab levels in patients with membranous nephropathy. And what we found was, 20 patients we tested, and none of the patients at the end of 3 months had, significant rituximab in circulation. Compared when you use it for maintenance regimen, podocytopathy or antivasculitis, they actually do well. So this is a study where we compared 60 plus patients with anti-PLA2R titer of more than 150, who were treated with either rituximab or cyclical cyclophosphamide. It was not a randomized; it's a retrospective observation study of these patients with high PLA2R titer. The proteinuria was largely comparable. PLA2R titer was comparable. The response rate was numerically better in the cyclophosphamide group, but it was not statistically significant, and it was a reasonable sample size. And the adverse events were clearly better with rituximab compared to cyclical cyclophosphamide, suggesting that in high anti-PLA2R titers, you could use rituximab. And when we used rituximab in these patients, we gave most of the patients CD19 targeted rituximab, where at the end of 3rd month, if they had repletion of the B cells, we topped them with additional dosing. So the next is about patients with kidney dysfunction. So what is the evidence of rituximab or any other medications in patients with kidney dysfunction? So if you look, this is a study which was published in Lancet in 2013. And among all the membranous study till date, if you look at, this is one of the best studies that are done. Why? Because the population is a very rare population, where they included patients who had a drop in the GFR of 20%. Only those patients were enrolled. They were randomized to either receive chlorambucil plus cyclophosphamide or supportive care or cyclosporine. Long story short, in patients with deteriorating kidney functions or at risk of deteriorating kidney functions, they found that chlorambucil plus corticosteroids did well compared to suppurative care and cyclosporine therapy, suggesting that that is the basis why in patients with very high risk you give alkylating agents and corticosteroid as the first line therapy. So, is there any role of rituximab? This is the data from the French cohort, where 13 patients with 14 episodes of nephrotic syndrome were treated with either 1 gram on day 0 and day 15. That's the NICE protocol. 375 milligrams on day 0 and day 8. That's the GEM-RUTUX protocol. And what they found was, and these patients had a reasonably good biopsy parameters. The proteinuria decreased by 90%, and the serum albumin also improved. Close to 2/3 of the patients achieved clinical remission, and also improved. There was also an improvement in the GFR when compared to the baseline, suggesting that rituximab is effective in patients with CKD, that is severe CKD, that is 4 and 5. This is a study which we published in the Nephron, where 50 patients with a GFR of 30 to 60 who received either rituximab and cyclophosphamide, what we found was, the patients who received rituximab and cyclical cyclophosphamide, they had, similar remission rates, 42% numerically lower with rituximab compared to cyclophosphamide. The risk of death, doubling of serum creatinine or dialysis requirement was also comparable, although numerically it was higher with rituximab compared to cyclical cyclophosphamide and corticosteroids. However, it was not statistically significant. With respect to severe CKD, our cohort, what we found was 16 patients. Most of them were all severe, they also had IFTA of more than 50% on the biopsies. And they received 1 gram of rituximab on day 0 and day 15, or a CD19 targeted therapy where 375 milligrams was given, and additional dosing at 3rd month if that kind of response was not there, or CD19 repletion was there. 50% of the patients, even with advanced kidney injury and advanced histology, had remission of the nephrotic state. Serum albumin almost doubled, proteinuria reduced by more than 70%, and also there was a reduction in the creatinine from 3.2 to 2.2 milligram per decimeter, suggesting that rituximab is safe and effective in patients with even advanced kidney injury. So coming to the last part of the cohort is the management of resistant membranous nephropathy. So, there is no uniform definition for resistant membranous nephropathy. When PLA2R was unavailable, so the definition was, 9 to 12 months. You wait for about 9 to 12 months because membranous nephropathy is an indolent disease. It is well known that remission could take, 6 to 9 months. So you wait for about 9 to 12 months before you choose a second line therapy. However, with anti-PLA2R, you are reasonably, now you know that you can see the trend of the anti-PLA2R. If you see that the trend of the anti-PLA2R is not declining, so it means that the patient is likely to be resistant, and you may institute a second line therapy maybe earlier, maybe 6 to 9 months instead of 9 to 12 months in the pre-PLA2R era. So rituximab, what are the options? If the patient has received cyclophosphamide and corticosteroids earlier on, you can give rituximab. If the patient has received corticosteroids and cyclophosphamide, you could give rituximab. You can easily transpose one for the other. And if you look at the remission rates, about 2/3 of the patient treated with rituximab and resistant disease would achieve clinical remission. Compare with cyclical cyclophosphamide and corticosteroids, about 3/4 of the patients treated with cyclical cyclophosphamide and corticosteroids for resistant disease would respond. Tacrolimus, I say that CNIs are the best apology. Whenever you're also satisfied that you have done something. It induces remission in 30%, but the moment you stop, you have the disease coming back. So, and there is also a newer thing, which is the combination therapy. Combination means a hybrid of, using rituximab, low-dose cyclophosphamide, and low-dose corticosteroids. So this brings about remission in 68 to 100% of the patients with membranous nephropathy. So coming to the combination therapy, this is in patients with treatment-naive or relapsing disease. This is a study from the Nijmegen cohort where the patients were given a combination of low-dose corticosteroids. Low-dose corticosteroids here meant, methylprednisolone 2 doses, followed by 1 milligrams for 1 week, 0.5 milligrams for next week, and 0.25 milligram for 1 more week and stop. Or cyclophosphamide for 2 months. That's, they give at 1.5 milligrams for 2 months and stop. Rituximab 2 doses, day 0 and day 50. It was about close to 26 cases. The median anti-PLA2R was high in this patient. It was about more than 150. Proteinuria was high. Serum albumin was less than 2. And what they found was immunological remission of close to 90% was achieved within 2 months itself. And clinical remission also, 84% of the cases achieved clinical remission. With additional rituximab dosing between 6 to 12 months, 88% of the patients achieved clinical remissions. And also the complete remission was close to 40%. Otherwise, with rituximab, it's about 25 to 30%. And the regimen was well tolerated, and only 4 patients had serious adverse events, and one among them was pulmonary thromboembolism, which obviously is not because of the therapy, it's more because of the disease. So this is a study in which they used prolonged corticosteroids along with cyclophosphamide and rituximab, where they gave 8 grams of rituximab, to these patients over a period of 15 to 18 months. And 1/3 of the patients were relapsing. 15% of the patients were resistant disease. Anti-PLA2R was reasonably higher anti-PLA2R titers. What they found was 100% of the patient had immunological remission, 100% of the patients had clinical remission. This is a study from the Harvard University. I heard that a similar protocol was also used in patients with ANCA vasculitis. Another is this is a study from our unit where about 20 odd patients were treated with a similar regimen, and what we found was 1/3 were relapsing disease and 2/3 were resistant disease. And these are all difficult to treat because they had received multiple courses of cyclophosphamide and corticosteroids and rituximab, and anti-PLA2R median was about 139. And the immunological remission rates were very higher, but the clinical remission rate was only seen in 2/3 of the patients. In patients who did not respond, we did a biopsy, and what we found that most of these patients had actually advanced chronicity. And why these patients had a lot of proteinuria was because of the diffuse glomerulosclerosis rather than an activity. So the new kid in the block is obinutuzumab. Rituximab is a class 1 antibody which chiefly acts by complement-dependent toxicity, less because of direct toxicity, less by antibody-dependent cytotoxicity. Obinutuzumab it's a class 2 antibody. It is mainly by the direct, that is, antibody-dependent cytotoxicity is much higher with obinutuzumab vis-a-vis rituximab. And henceforth, what happens is it brings about greater depletion of the B cells, that it depletes the B cells in circulation and also in reticuloendothelial cells. Whereas rituximab, the depletion is only in the circulation. And if you want a pan B cell depletion, then you have the CAR T cell therapy, which General Verma spoke about. CAR T cell therapy is generally, it knocks off B cells from each part of the body. So what is the evidence with respect to obinutuzumab in patients with resistant disease to either cyclophosphamide and corticosteroids or to rituximab? You find that 80 to 90% of the patients achieve remission with obinutuzumab. In patients who are allergic to rituximab, you can conveniently give obinutuzumab. We are given it to our patients. And also another important fact, an investigation that we were a part of is looking at rituximab antibodies. Suppose you give 100 patients rituximab today, at the end of a year, you will find that, close to 1/3 of the patients have anti-rituximab antibodies. If these patients develop a relapse of nephrotic syndrome, they are less likely to respond to rituximab. And in these situations, if you use obinutuzumab or ofatumab, they are likely to respond better. They induce remission in close to 90% of the patient compared to only 1/3 with rituximab-based therapy. This is, every other month, if you look carefully, you will have one or the other study which is coming from China with respect to obinutuzumab. And this is a nice study where they compared 21 patients treated with obinutuzumab and compared it with patients who were treated with rituximab by a propensity match scoring. Propensity match scoring essentially means that, try to match for the baseline parameters. That is the proteinuria, anti-PLA2R titers, serum albumin level, and the GFR between the two groups. What they found was 95% of the patients treated with obinutuzumab had clinical remission compared to 2/3 with rituximab, which is, I think, similar to what we have seen in our patients with resistant disease as well. And also the complete remission, as I said, with rituximab, complete remission is about 20 to 25%, and in Chinese cohort it was 14%, compared to 38% with obinutuzumab treated patients. And immunological remission was certainly better with obinutuzumab compared to rituximab, suggesting that, obinutuzumab is a better agent to rituximab in patients with membranous nephropathy. There is a clinical trial which is ongoing comparing obinutuzumab to, tacrolimus. That's the Majesty trial. So about 140 patients with membranous nephropathy are randomized to receive either obinutuzumab or tacrolimus. We will hear the results soon, maybe in the next ASN. Then there is also, another Blossom trial, which is obinutuzumab versus cyclical cyclophosphamide and corticosteroids from China, which is ongoing. There is a reboot trial. These are the newer trials in pipeline. There is a reboot trial, which is belimumab plus rituximab versus rituximab and placebo, which is ongoing. There is another study with iptacopan versus rituximab in membranous nephropathy. To my best, this study is halted because, I don't think the results are promising, and the study is halted. But I may be wrong. I think you should check upon this. So the last part before the anticoagulation is about NEL1 associated membranous nephropathy. We know that there are multiple phases of NEL1 associated membranous nephropathy. What is relevant to India is, you should remember, is patients with complementary medicine, especially Siddha medicines or skin whitening creams, where there's a lot of mercury. Mercury acts as a hapten. It binds to NEL1, exposes the NEL1 to circulation, and they develop antibodies to NEL. And then you have membranous nephropathy. And the best thing is, if you withdraw the inciting agent, that's the cream or the complementary medicine, 2/3 to 3/4 of the patients would have remission of the proteinuria and would achieve complete remission in these patients. So this is an important concept. That is why it's what. And NEL1 is generally identified by immunofluorescence. They have segmental positivity for IgG and C3. And you can easily do a NEL1 staining. And NEL1, you had General Narula speaking about the various immunoglobulins, thrombospondylin and PLA2 or IgG4, whereas NEL1 is IgG1 dominant. You can also have IgG4, but they're IgG1 dominant. The last but not least is anticoagulation in membranous nephropathy. Membranous nephropathy is associated with increased risk of thrombosis. I don't know if somebody attended the CPC that was presented in a couple of weeks ago from PGI, where we had a patient with unknown cause of pulmonary thromboembolism, and it was diagnosed as a case of membranous nephropathy. The risk of thrombosis varies from 7 to 45% depending upon how well you screen and how well you don't treat. So then among all proteinuria, albumin, PLA2R, and then, the GFR, the most important predictor is serum albumin. for every gram reduction in the serum albumin, the increased risk of thrombosis, the risk of thrombosis goes by 2 times. And if there is any bitter spot for the protein, for the serum albumin level below which the risk is very high, I think it's 2.8 grams. Less than 2.8 grams, it's 9.4. That is close to 10%. Compared, if it is more than 2.8%, it's only 3%. So only thing is there are concerns about monitoring and the fear of bleed. What is the anticoagulation of choice? All the guidelines, if you look, they recommend vitamin K antagonist. However, the problem with vitamin K antagonist is, patient will have to come multiple times before you get their INR set to about 1.5 to 2.5. Whereas with the non-vitamin K antagonists, the novel agents, it is easy to use, especially apixaban. So, although the guidelines do not recommend, that is what is practiced more common these days. Only problem with using the apixaban is there is a risk at both the ends. It is protein bound. So there is increased risk of its loss in the urine, so decreased activity. Because it is protein bound, there is also a theoretical risk of increase in the free apixaban level in the circulation, So there can be increased risk of bleed also. So in our study of about 60 patients who were treated with apixaban prophylaxis, only one patient had menorrhagia. Otherwise, there was no any safety signals was not there. Always remember that you can use a NOACs as a primary prophylaxis. But if somebody has detected thrombosis, make sure that these patients are on vitamin K antagonist and not on novel agents, that is non-vitamin K agents alone. So coming to the end is, if I have to, summarize my presentation, be careful about at least 10 points in managing membranous nephropathy. One is conservative care. If you have an high PLA2 or antibodies, don't choose to wait. You can treat the patients upfront. And anti-PLA2 or monitoring, you need to do at the baseline and at the 3 months and at 6 months. The trend is very important. Anti-PLA2 or at 3rd month is important in deciding the course of, the disease. In patients with severe CKD, treat them with, that is CKD 4 and 5. It's better to use the cyclophosphamide and corticosteroid because they have benefited with disease progression. But if there is a contraindication, don't hesitate to use rituximab. There is evidence for that. Malignancy with cyclophosphamide is something that I do not touch. It's only seen if the patient's cyclophosphamide dose beyond 36 grams. And if you look carefully, I showed that in modified Ponticelli, it's about 13.5 grams. So malignancy is not a big risk if you are using the modified Ponticelli protocol, that too only once. Fertility is a serious issue. If you have, it's a disease of middle-aged. So if you use cyclophosphamide, that is 13.5 grams of cyclophosphamide, there is high risk of, amenorrhea in patients, especially, amenorrhea is in the ladies. So, there is a risk of toxicity is more in females compared to males. Then anticoagulation, make sure that you give anticoagulation to your patients, especially the serum albumin is less than 2.5 and there is no risk of bleed. And you could use, NOACs for primary prophylaxis and vitamin K at least for secondary prophylaxis. And do not forget to add additional rituximab dosing at the end of 3 to 6 months because your rituximab level disappears at the end of 3 months. And the patients, if you give an additional dose, there is increased immunological and clinical remission. When you are using corticosteroids and cyclophosphamide, make sure to discuss this aspect of withdrawal symptoms. Otherwise, these patients will reduce the dose of cyclophosphamide because they will attribute all the withdrawal symptoms to cyclophosphamide and there would be a non-compliance. Do not forget to vaccinate your patients. During COVID times, it was the COVID vaccination and now it's the zoster and the other vaccinations. And also, do not forget to test for core antibodies for hepatitis because it's fairly common in the Asian population. Last but not least, do not forget to administer cotrimoxazole prophylaxis. You need to give it for at least 6 months, whether you use rituximab or cyclical cyclophosphamide and corticosteroids. Thank you all for a patient hearing and be happy to discuss. I did not deliberately touch upon the multi-targeted therapies so that we can discuss those in the discussion part.
Thank you, Raja. I think that was excellent. That was a detailed and required talk on membranous nephropathy. And you being involved in many of these trials, I think there can't be a better person to discuss membranous nephropathy. Just one or two small questions, then because we have exceeded much of the time, but every students are still glued up. It is 8:20. Small question, because whatever the trials with rituximab have been, but we find the results of cyclophosphamide are better. But have anybody measured antibodies in the previous studies? Because, as you rightly mentioned, probably one third or more of them are developing rituximab antibodies. And logically, it is getting cleared from circulation. So, where is the rituximab left? You are having that data that everybody has not given every 6 monthly. So nobody possibly studied the rituximab antibodies that time. Maybe the results are bad because of that. That
Maybe
is
so.
one query. Second, we all talk of thromboembolic phenomena, and we also say the worst disease for thromboembolic phenomena is membranous nephropathy, which is followed by maybe FSGS or lupus and all. Why particularly? It's not related to albumin level. Why membranous people have got the most hypercoagulable state?
Okay.
Just two of these questions. Then the audience has got many questions. I'll put one or two questions from them.
Sure, sir. So the first question is why there is a poor response to rituximab. So if you carefully look at the biology of rituximab, which fortunately I was able to do, what I found was at the end of third month there is a disappearance of rituximab. And
Correct.
what we do now is we give an additional dose, 1 gram of rituximab in between month 3 and 4. And what we found was, the remission rate increases by 10 to 15%. So, you reach close to 80% with rituximab itself. So, it's actually, you lose all the rituximab. So, if you will have to top up with rituximab. If you top up with rituximab or give a booster dose, whatever you call it as, these patients respond. One. So, that is, I think, the primary reason, sir. With respect to antibodies, I think, it has not been done. It's only done by the French people, and they had asked us for a collaboration, and we measured the antibodies in our population. We found that in 1/3 of the cases, it's
Yeah.
actually relevant to the second episode that comes, not to the primary episode, because at the end of 1 year, you're going to measure the antibodies. So the antibodies
9
are
months.
actually relevant at the end of an year. So it's mainly for the relapse. So even if anti-rituximab antibody is interesting, if you look at patients with pemphigus, skin condition, there also they have close to 1/3 of the patient develop antibodies, but they do not predict, the response to, the relapses in the pemphigus patients. Whereas that is slightly different in the Indian cohort, like in the membranous cohort, not Indian cohort, in the membranous cohort. So
Question from audience. When to stop therapy? Should there be a maintenance for long term or 6 months is enough?
So there is nothing like maintenance therapy in membranous nephropathy. So to be
Yeah.
honest with you,
Yeah.
you give it only in
Correct.
podocytopathy, especially in steroid dependent and frequently relapsing state where there is a steroid dependent status. Otherwise, you don't give maintenance. So you only treat, get the antibody to negativity, and then stop. You don't actually, give maintenance.
Role of any chelating agent for mercury in NEL1 membranous?
We have seen sky high cases of patients with mercury levels and membranous nephropathy. Largely, these patients are polysymptomatic, but for the edema, they don't develop other features of mercury intoxication. So only for kidney limited, there is no role of chelation, because the mercury levels will go down by maybe 6 to 8 weeks. It will go away. Sometimes it can take 6 months, but you will find that the mercury goes off. So it's for kidney alone, it's not an indication to chelate. Patience is the key.
I think we will just take the last one. For a primary membranous plateau and membranous at 3 months, there is no decrease in proteinuria. And let's say plateau also remains positive, but CD19 is depleted. Should we repeat Rutux or consider switching to modified Ponticelli?
So I think the question is very relevant. We often see you have, so I'll clarify this question better. So you have an anti-PLA tumor of 200. You're treated with rituximab. It has stayed largely the same. It's come down to 180, but obviously from 200 to 180 is not much at the end of third month. CD19 is depleted obviously because you have some rituximab in circulation that will deplete. Even if you give 100 milligrams of rituximab, it will deplete all the B cells. So that is not the key. Do not focus on the CD19 cells. Your focus should be on PLA2R and the the proteinuria. So you give the third month dose. You give an additional top-up dose in between third and the fourth month. You wait for 6 to 8, 9 months. Because membranous nephropathy is an indolent disease. So, you can wait for 6 to 9 months. There is no hurry. Just make sure that they give ACE/ARBs and anticoagulation to these patients. I wouldn't rush. Why I was able to tell you these numbers is because today only I took a decision on such a patient.
Okay. Last, but there's a very long history given by Dr. Mitesh. Elderly 65-year-old man, diabetes for 15 years, diabetic nephropathy, NPDR, requiring 2 antihypertensive, creatinine 2.2, found to have nodular opacities in mediastinum and generalized lymphadenopathy, hypercalcemia, probably sarcoid, PET scan, lymph node positive for activity, ACE negative, biopsy non-necrotic granuloma, TB workup negative, mass spectrometry for amyloid awaited, 24-hour protein 5 gram, albumin 3.3, did a renal biopsy, 20% IFTA, 7 out of 12 glomeruli sclerosed, 2 out of 12 global segmental sclerosis, that is 9 out of 12 were gone. PLA2 receptor NEL double positive. PLA2 also and NEL also, serum PLA2 negative. Congo red negative for amyloid. The methodological plan is to treat for case as sarcoidosis. I have planned to keep it as primary membranous, but I don't know of any targets to achieve, and I'm confused if the candidate is for rituximab in view of the serum being negative.
Yeah, so it's an interesting case. So, if I have to speak about sarcoid and membranous nephropathy, we have a cohort of about 15 cases. And, half of them are like this only, diabetic patients. So you don't know what to do. I think 10 of our patients were treated with cyclophosphamide and corticosteroids. In 5 of the patients, we gave rituximab only because, they had a contraindication for corticosteroids because their diabetes was poorly controlled. So what I found was, most of these patients had remission of proteinuria. I would say that I only recollect only one patient who did not respond to, cyclophosphamide or rituximab among these. If you look at the PLA2R and NEL1 associations with sarcoidosis, a PLA2R associated membranous nephropathy is very well described with sarcoidosis. Most of these patients have anti-PLA2R positive also, but in your patient, it may be a low titer positivity. That is why everything in kidney is acting like a sink and absorbing all the antibodies. I would encourage you to treat this patient with rituximab and wait for a response. However, if there is a dominant extra renal manifestations, I would suggest you to go for corticosteroid based therapy instead of rituximab based therapy.
I will stop here. Only 3 comments from 3 seniors who are sitting here. I must thank you before I close. I enjoyed it. I enjoyed the talk, and it was very useful to students, and over 100 of them are still glued. First, comment by expert Dr. Rajapurkar. Second, Dr. Girish Narayan is raising his finger. Third, Professor Narula. So let them have one comment, and then we close the session. Professor Rajapurkar first.
Excellent lecture I heard from Raja, and revised a lot of things for me. I was feeling a bit not up to date. So this was good for me. So anticoagulation, and maybe when you're treating a nephrotic syndrome, you need to concentrate also on the amount of protein that the patient's diet should have. The salt restriction is extremely important. And therefore, and I would think that at least in this present case, I would have also treated it early rather than late, and would have added a apixaban.
Professor Girish Narayan.
Yeah. Excellent presentation by all the panelists, especially Dr. Raja. Now, a small comment or doubt, Dr. Raja, or the other panelists. This index case to such a severe proteinuria, which is considered as a moderately severe risk, is it worth still trying with rituximab to begin with, or do we go it with a better therapy or like cyclophosphamide for such severe cases? What would be practically what would be the approach? Although, what is your suggestion in such type of cases?
But to be honestly, I missed the starting part of the presentation. So my choice with somebody with 8 grams of proteinuria who does not have a contraindication to cyclophosphamide and corticosteroid, like being a diabetes, no age and other things I wouldn't choose as a contraindication. But if there is no diabetes or anything, I would choose to treat this patient with cyclical cyclophosphamide and corticosteroids. Primarily because now, sir, this patient actually received rituximab and was having a severe reactions to it. If there is no rituximab reactions, you can choose to treat such patients with rituximab alone and just wait, sir. Proteinuria is, I know that high proteinuria is an issue, but these patients do respond to repeat course of rituximab.
Yeah.
It's a safe
She was a
measure.
28-year-old lady, so logically, rituximab would have been the first choice for her. Yeah,
Yes.
yeah. Professor Narula.
Yeah, thank you very much, Raja, for that wonderful discourse. Now, in this particular case, who is allergic to Retux and who had allergy to, who had TAC toxicity, you spoke about obinutuzumab as a potential benefit
Yes, sir.
in this particular lady. So I suppose that's the next most logical choice rather than cyclosporin.
Sir, in this patient, my choice would be cyclosporin, MMF, and steroids. I did not deliberately keep that slide, sir. There is a Chinese study which was published, randomized trial, where they compared cyclosporin, MMF, and corticosteroids compared to modified Ponticelli protocol. And what they found was 79% of the patients responded, sir. So I think this would be the next logical step. Why I say the next logical step and not obinutuzumab is, unfortunately, obinutuzumab is withdrawn from the market for the nephrologist. So, that's the biggest problem. We have a couple of patients and they said that, it's not available to for nephrologists. So I think if you ask me, I think I would choose this combination, sir, like,
I think my profuse thanks to Raja, Professor Rajapurkar, and Professor Narula for presenting a very good case. And don't get the first year resident. You did a reasonably good job. And for teachers like Rajapurkar and all, they have to point out some mistakes. So don't feel bad. It is just for the improvement and say good experience to start the session, to start first year by presenting in a national forum. Uh, Once again, thank you everyone, and we close the session now. Thank you once again, Raja, and thank you, Steadfast.
Thank you, everyone.
Thank you, our senior and respected faculty, for such an amazing session. Thank you and good night.
Good night.